Welcome back to the Deep Dive. Today we're doing something a little bit different, something a bit more specialized. We are, for want of a better word, trading the casual observation deck for the operating theater. We are scrubbing in.
It's definitely a shift in gears. Usually we're taking this broad look at a topic, but today, we're zooming in with surgical precision.
We are. We're creating what we're calling a medical school companion edition. Our source material today is, well, it's legendary.
Oh, it is.
If you've ever walked into a surgical registrar's office, you've seen it on the shelf. It's the Bible of surgical practice. Baily and Love's Short Practice of Surgery.
Yeah.
And specifically, we are cracking open the 28th edition to dissect Chapter 45, Skin and Subcutaneous Tissue.
It's a rite of passage. I mean, you can't really call yourself a surgeon until you've grappled with Baily and Love. It is dense, it's comprehensive, and let's be honest, it can be pretty overwhelming.
That is exactly why we're here, to act as the translator, really. Our mission is to interpret and, simplify this huge chapter. Think of this as your audio anchor. We want to lodge these concepts in your brain so that when you're on rounds or staring at a scary-looking rash in the ER, the answer just pops up.
But we need to be absolutely crystal clear about the rules of engagement here. This deep dive is an interpretation. It's a supplement.
Right.
It does not replace reading the actual text.
Absolutely not. You can't learn surgery by osmosis. You still need to open the book for the diagrams, the fine print, the histology slides, and, those terrifying T&M staging tables.
We're here to help the reading make sense, to give you the framework to hang all those details on.
So consider us your revision partners. You're the one doing the heavy lifting, reading the text.
And I'm here to help distinguish the need to know from the nice to know.
Perfect. So I'll play the role of the exhausted junior doctor trying to make sense of it all, and you're the senior consultant guiding my hand.
Sounds about right.
We've got a lot of ground to cover. Anatomy, some genetic disasters, the messy world of infections, all those confusing lumps, and then finally the big three malignancies.
It's a long list.
It is. So let's start at the very beginning. The canvas, anatomy and physiology. So the text describes the skin as a layer cake, which I like, but the proportions seem completely off.
They are. They're massively disproportionate. The epidermis, that's the outer shield we actually see and touch, is incredibly thin. It's only about 5% of the skin's total thickness.
Just 5%.
Just 5. The dermis, which is the infrastructure underneath, that's the other 95%.
Wow. Okay, so that 5% does a lot of work for being so thin. The book lists all these Latin layers for the epidermis, stratum basalis, spinosum, granulosum, lucidum, corneum. When I read that list, my eyes just glaze over. How do we make that stick?
Okay, don't think of it as a list. Think of it as a career ladder, or maybe even a tragic life story.
Tragic life story. Okay, I'm listening.
You start at the bottom, the stratum basalis. These are the young, ambitious interns. They're cuboidal cells. They have big nuclei. They are metabolically active, dividing constantly. They're alive and kicking. This is where all the work happens.
So they start at the bottom, fresh-faced and full of energy.
Exactly. But then they get promoted or, pushed up into the stratum, spinosum, and granulosum. And as they climb this ladder, the pressure increases. They start working harder to produce keratin, that's the protein armor, but in the process they start to burn out. And by the time they reach the top, the stratum corneum, they have sacrificed everything for the job.
Sacrificed everything? What do you mean?
I mean, they lose their nuclei, they lose their organelles, they literally die. The stratum corneum is just layers and layers of flattened, dead cell carcasses packed with keratin. It's a graveyard.
Wow.
But that graveyard forms the waterproof protective shield that keeps us alive.
So the skin we actually see.
Yeah.
It's just the toughened ghosts of the cells that used to be at the bottom.
Precisely. And beneath that layer of ghosts is the dermis, the 95%. This is the city infrastructure.
Yeah.
This is where you have the collagen for strength, elastin for stretch, the nerves, the blood vessels, all the important stuff.
Okay, speaking of infrastructure, how do you keep the top layer attached to the bottom one? I mean, if the epidermis is just this thin sheet, why doesn't it just slide off when I rub my arm?
That's a dermoepidermal junction. If you look at it under a microscope, it's not a flat line. If it were flat, the skin would shear off constantly.
Like a blister waiting to happen.
Exactly. Instead, it's this three-dimensional wave. The epidermis sends down these fingers, called right burr ridges, and the dermis pushes up fingers called papillae. They interlock.
Oh, like Velcro.
Exactly like Velcro.
Wow.
Or the teeth of a zipper. That interdigitation increases the surface area massively, and it locks the two layers together so they can withstand those lateral shear forces.
I see.
When you see a blister, that's usually where that Velcro has been ripped apart or fluid has built up between the layers.
That makes so much sense. Okay, now, Baily and Love introduces a concept here that feels very, I don't know, plastic surgery specific, but they emphasize it heavily. The angiosome.
Crucial concept.
I've read this definition 3 times. A composite block of tissue supplied by a specific source artery. I'm picturing like a Lego block.
A Lego block is a decent start, but let's try a quilt analogy. Imagine the human body is a quilt made of all these different patches. Each patch is a 3D block skin, fat, fascia, maybe even the muscle underneath.
Okay.
And each one of those patches has its own dedicated power cord, a source artery plugged right into the center of it.
A quilt of tissue blocks, each with its own plug. Got it.
Right. Now, normally the blood stays mostly in its own block, but let's say you're a surgeon and you need to move a piece of skin from the belly to cover a hole in the chest. You're going to lift that flap of tissue. When you lift it, you might have to cut the direct power cord to a part of it.
So the tissue should die then, right? You cut the cord.
It would die except for the choke vessels. These are the secret doors between the neighboring blocks. Yeah. Normally they're closed or they have very low flow. But if the pressure drops in one block because you've cut the artery, these choke vessels dilate. They open up wide and allow blood to rush in from the neighbor.
So it's like emergency backup generators kicking in from the room next door.
That's a perfect analogy.
Yeah.
And understanding these territories and the choke vessels that connect them is how surgeons design flaps, like the tram flap for breast reconstruction.
Yeah.
You are banking on those choke vessels to keep the farthest tip of that skin alive.
That is fascinating. It's plumbing and engineering, really.
It is.
One other thing on physiology before we move on. The book mentions that skin has a blood supply 20 to 100 times greater than its metabolic needs. That sounds, incredibly inefficient. Why does it need so much blood if it's mostly dead cells on top?
It's not for feeding the cells, it's for the radiator.
The radiator?
Yeah. We're warm-blooded animals. We flush blood to the skin to dump heat. That's thermoregulation. But there is a huge surgical upside to this inefficiency. It means the skin is incredibly robust. Because it's used to being so over-serviced, it can tolerate starvation better than almost any other organ.
Oh.
If you cut the blood supply to a kidney, it dies in minutes. You cut the blood supply to skin like in a skin graft, it can survive for days just by soaking up plasma from the wound bed before new blood vessels can connect.
It buys you time.
It buys you survival. Simple as that.
Okay, let's move to part 2. When the blueprint fails, we are talking genetics and radiation. And the biggest enemy here is obviously the sun.
Ultraviolet radiation.
Yeah, VR.
The text breaks it down into UVA and UVB. I always get these mixed up. Which one is the really bad one?
They're both the bad one, but for different reasons. You need an anchor to keep them straight. So UVA has a longer wavelength.
Okay, long.
And because it's long, it penetrates deep right down into the dermis where the collagen is. It just smashes up the collagen and elastin. So think A for aging.
UVA is what gives you wrinkles. Yes. It causes solar elastosis, that sort of leathery, yellowed look you see on sailors or farmers. It doesn't burn you as much, but it ages you. Now, UVB, shorter wavelength, higher energy, it hits the epidermis and stops there.
Okay.
It acts like a shotgun blast to the DNA. Think B for burning.
A for aging, B for burning, and UVB is the one that's messing with the genes.
Specifically, it causes a mutation in the P53 gene, and that's the guardian of the genome. When P53 is broken, cells with DNA damage don't commit suicide like they're supposed to.
They just keep going.
They survive, they replicate, and eventually they become cancer.
Speaking of broken genes, Baily and Love lists a few genetic syndromes that are absolute exam favorites. You know, the conditions where the skin is basically waving a big red flag saying something is wrong inside.
We call them neurocutaneous syndromes. And you're right, if you spot the skin sign, you've basically diagnosed the systemic disease.
Let's run through the big ones. First up, neurofibromatosis, NF1.
Ah, von Recklinghausen's disease. Chromosome 17. The classic sign is the cafe au lait spot, coffee with milk.
But lots of people have birthmarks. How do you know it's NF1 and not just a birthmark?
It's the quantity and the quality. You're looking for 6 or more spots, usually larger than 5 millimeters in kids. And then you look at the borders, the text distinguishes between coast of California, which is smooth, regular curves,
Right.
and coast of Maine, which is jagged and irregular. NF1 spots are typically smooth, like the coast of California.
And what if you press on the fleshy bumps they get?
The buttonhole sign. If you press on a neurofibroma, it feels like it pushes deeper into the subcutaneous tissue, like pushing a button through a buttonhole. So you see cafe au lait spots, armpit freckling, and these soft bumps, that buttonhole. You're thinking NF1?
Next one, Gorlin syndrome. This one just sounds like a curse.
It's a heavy, heavy burden. It's also called Nevoid basal cell carcinoma syndrome, chromosome 9. The clue is right there in the name. These patients, and they're often young, in their teens or 20s, start popping out basal cell carcinomas, BCCs, everywhere.
A 20-year-old with skin cancer is already a massive red flag.
Exactly. But here's the connection that gets asked in exams. Look at the jaw. These patients get odontogenic keratocysts in the mandible. So if you have a patient with a jaw cyst and a weird rash of skin cancers, it's Gorlins.
Jaw cyst plus skin cancer equals Gorlins. Got it. What about xeroderma pigmentosum?
This is one of the saddest conditions in medicine. It's an autosomal recessive defect where the body simply lacks the enzyme to repair DNA damage from UV light.
So they have zero defense against the sun.
Zero. A normal person gets a sunburn, the DNA breaks, the enzymes come in and fix it. These kids get a sunburn, the DNA breaks, and it stays broken.
Oh, it's awful.
They develop aggressive cancers, BCC, SCC, melanoma, before they even hit puberty. They have to live their lives in total darkness.
Just devastating. Okay, last one in this section. Gardner's syndrome.
This is a classic skin as a window case. Gardner's is a variant of familial adenomatous polyposis, or FAP. So these patients have thousands of polyps in their colon that will turn into colon cancer. But before the colon cancer gets them, the skin gives a warning. They get epidermoid cysts and osteomas, bony lumps, usually on the skull or the jaw.
So a lump on the head could predict cancer in the gut.
Precisely. You find an osteoma on the skull of a young person, you need to ask about their family history of bowel cancer and probably get them scoped.
Okay, let's do a quick check-in. We've covered a lot of dense biology there. Listener, I'm putting you on the spot.
Imagine you are the junior doctor in clinic.
A 19-year-old male comes in. He's complaining about his wisdom teeth hurting. You take an x-ray and see multiple cysts in his jawbone. While you're talking to him, you look at his face and notice he has 3 or 4 small, pearly sores that look a lot like skin cancer. What is the diagnosis and which chromosome is broken?
Think back. Jaw cysts plus early skin cancer, that's the pattern. The diagnosis is Gorlin syndrome and the chromosome 9.
Did you get it? If not, just rewind and listen to that exam favorite section again. These patterns are the key to the castle.
They absolutely love asking that one.
All right, moving on to part 3. The red and the angry. Infections. The skin is a fortress, but bugs are always trying to storm the gates.
And they often succeed.
Let's start with the basics. Impetigo, the school sore.
This is pediatric bread and butter, staph or strep bacteria. The visual anchor you must remember, and I mean, you need to visualize this, is golden honey-colored crusts.
Like someone glued cornflakes to their face?
Exactly. Like someone smashed sugary cornflakes onto the kid's chin and stuck them there with honey. It's weeping, it's crusty, and it is incredibly contagious.
Now, for the adults, erysipelas versus cellulitis. In the real world, everyone just says cellulitis for any red leg. But Baily and Love insists they're different.
They are different, and the difference is all about depth. Erysipelas is an infection of the upper dermis and the superficial lymphatics. Because it's so shallow, the skin is intensely red, it's shiny, and this is the key. It has a sharp raised edge.
A sharp edge.
Yes. You can literally feel the step from normal skin to infected skin. You could draw a line around it with a pen and be accurate to the millimeter. It's often on the face or the ear.
Okay, so a cliff edge and a cellulitis.
Cellulitis is deeper. It's in the subcutaneous fat. And because it's under that thick dermis, the redness is more diffuse. The edges just fade out. It's pink, swollen, hot, but you can't tell exactly where it stops. It's a slope, not a cliff.
Cliff edge equals erysipelas. Fading slope equals cellulitis.
Got it.
Got it. Now, let's talk about hidradenitis suppurativa. This sounds like an absolute nightmare for patients.
It is a misery. It affects the apocrine gland areas, so armpits, groin, under the breasts. And it's not just bad acne. It's a chronic, relapsing inflammatory disease where the hair follicles clog up.
The follicular occlusion triad.
Correct. The follicle blocks, it ruptures, and that causes these deep, painful abscesses. These then heal with scarring, forming sinus tracts tunnels under the skin that constantly leak foul-smelling pus.
And it's linked to lifestyle, isn't it?
Heavily. Smoking and obesity are the big drivers. But telling a patient to just stop smoking doesn't fix the scarring that's already there. Often, we have to surgically excise the entire area, skin, fat, glands, everything, to stop the cycle.
Okay, we need to shift the tone here. We need to talk about the killer, the absolute siren alert of dermatology, necrotizing fasciitis.
This is the one diagnosis you cannot afford to miss. The mortality rate is 30 to 50%, even if you treat it correctly. If you miss it, it's 100%.
Help us spot it. Because early on, it can look just like cellulitis, can't it?
It can, but there are clues. Let's create a scenario. A diabetic patient comes in, maybe they had a tiny scratch in their leg, maybe nothing at all. They look unwell, they're tachycardic, the leg is a bit red. But here is the sign. Pain out of proportion to clinical signs.
Unpack that for me.
You look at the leg, and it's a bit pink. It doesn't look that angry. But you lightly brush the bedsheet against their toe, and they scream in agony. They're climbing the walls with pain. That disconnect, a mild look, but extreme pain. That is the fascia dying and screaming.
And when you actually touch the leg firmly,
it feels woody, hard, like a table leg, not a soft, fleshy leg, and you might feel crepitus, a crackling, popping sensation like bubble wrap under the skin. That is gas being produced by the bacteria as they eat the tissue.
Okay, so if I see this pain out of proportion, woody feel, maybe gas, do I send them to CT?
You can, but only if the scanner is free right now. Time is tissue. The real test is the finger test.
A finger test.
You take the patient to theater. You make a small incision under local anesthetic. If you see dishwater pus, this gray, thin, foul-smelling fluid come out, you can sweep your finger along the fascia with no resistance because it's all detached and rotten. That is a positive test.
Okay.
Then you wake the anesthetist up and you cut. You perform a radical debridement. The rule is cut until it bleeds. Dead fascia is gray and doesn't bleed. You have to keep cutting until you hit healthy, red, bleeding tissue. It looks barbaric, but it is the only way to save that patient's life.
Cut until it bleeds. Wow. I will never forget that. That is intense. Let's take a breath and step back to something less lethal. Part 4. Lumps, bumps, and cysts.
The bread and butter of minor surgery.
Let's talk cysts. Patients call everything a sebaceous cyst. Are they right?
Almost never. A true sebaceous cyst is actually quite rare. What they usually have is an epidermoid cyst. It's a sac lined with epidermis that has somehow gotten lost under the skin.
And how do I spot one from across the room?
You look for the punctum. It's a tiny, dark dimple or a little hole in the center of the lump. That punctum is the blocked opening of the hair follicle where the whole trouble started. It anchors the cyst to the skin.
So if I want to remove it, can I just squeeze it out?
Absolutely not. That is the cardinal sin of cyst removal. If you squeeze it, you might get the cheesy keratin out, but you leave the cyst wall behind. And that wall is living tissue. It will just refill. To cure it, you must dissect out the entire sac without bursting it. You have to remove the factory, not just the product.
The factory, not the product. I like that. Now, moles, naive. The text uses a really helpful framework to understand how moles change as we grow up. It's a migration story.
Yes, exactly. Think of the melanocytes, the pigment cells, as dropping down from the surface over time. So stage 1, junctional nevus, this is childhood. The cells are sitting right at the junction of the epidermis and dermis. Because they are high up, the mole is flat and dark.
Okay.
Stage 2, compound nevus, this is adolescence. Now, some cells start dropping down into the dermis, but some stay at the junction. So the mole becomes raised, a bump, but it's still pigmented.
Right.
Stage 3, intradermal nevus. This is the adult phase. All the cells have migrated deep into the dermis. The mole is now raised, it's soft, fleshy, and it often loses its color. It might even grow a hair.
So the natural progression is flat and dark in a kid, to bumpy and dark in a teen, to bumpy and pale in an adult.
Correct. So if you see a fleshy, pale, hairy mole on a 50-year-old's face, that's normal. If you see a brand new, flat, black mole on that same 50-year-old, well, that breaks the pattern. That's suspicious.
That's a great rule of thumb. What about the imposters? The text mentions the Spitz nevus.
The Spitz nevus is a headache. It's a rapidly growing pink or red dome-shaped nodule, usually on a child's face or leg. The problem is, under the microscope, it looks terrifyingly similar to melanoma.
So is it cancer?
No, it's benign. We used to call it juvenile melanoma, but it's not. But because it's so hard to tell the difference, we usually excise them anyway just to be safe. You don't want to gamble on a maybe with a child.
Right. And what about the blue nevus? Why is it blue? Melanin is brown.
It's the Tyndall effect. It's physics. The pigment is very deep in the dermis, Long wavelengths of light, like red, get absorbed by the skin, but the short wavelengths, blue, scatter back to your eye. It's the same reason the sky is blue.
So a blue mole isn't necessarily dangerous, it's just deep.
Correct, though any new blue lump always needs checking out.
Time for check-in. Question number 2. Let's test that observation skill. You are examining a teenager's back. You see a mole, but surrounding that mole is a perfect white ring of depigmented skin. It looks like a target, a bullseye. What is happening there?
That is a halo nevus. The white ring is the clue. It means the patient's immune system, specifically their T cells, has decided that that mole is an enemy. It is attacking and destroying the melanocytes, causing the pigment to disappear.
Is that cancer?
Usually no. It's a benign autoimmune reaction. The mole will often vanish entirely over time. However, we always do a full skin check because sometimes, very rarely, a nasty melanoma somewhere else can trigger the immune system to attack all the moles. But in a teenager, it's almost always innocent.
Okay, deep breath. We are entering the danger zone. Part 5, the malignancies. We'll start with the non-melanoma skin cancers, BCC and SCC.
These are the most common cancers in humans, period.
Let's start with basal cell carcinoma, BCC. The book calls it the rodent ulcer, which is a pretty grotesque name.
It's an old descriptive term. If you leave a BCC for 20 years, it doesn't spread to the lungs or the liver. Instead, it just eats the tissue locally. It gnaws away at the nose or the eye, like a rat.
But generally it's slow.
Very slow.
What are the visual anchors? If I'm looking at a patient's nose, what screams BCC to me?
You need to look for the pearly rolled edge. The border of the ulcer looks like a string of tiny translucent pearls. Also, look for telangiectasia, those tiny spiderweb blood vessels running over the tumor. And often there's a central scab that bleeds, heals, and then bleeds again.
That classic history. Doctor, I have this shaving cut that just won't heal.
That is it. It's been there for 6 months. It keeps scabbing. Oh, I thought it was nothing. That's a BCC until proven otherwise.
Now treatment. If it's on the back, you just cut it out. But what if it's on the tip of the nose or the eyelid? You can't just hack away a huge chunk of that.
And this is where most micrographic surgery is the absolute gold standard. It's a meticulous process. The surgeon removes the visible tumor with a very, very tiny margin. Then, while the patient waits with a bandage on, they take that tissue to the lab immediately.
They check it right then and there.
Yes. They freeze it, slice it, and map it like a pizza. They can see exactly where the cancer roots are extending. If the map shows there are still cancer cells at the 3 o'clock position, the surgeon goes back and takes a tiny sliver just from 3 o'clock.
So it saves healthy tissue.
It saves the maximum amount of healthy tissue while guaranteeing you got all the cancer. It's essential for the face.
Okay, now, the other one. Squamous cell carcinoma. The aggressor.
The aggressor. Unlike BCC, SCC can metastasize. It can travel to the lymph nodes and it can kill you.
And what does it look like? Is it as obvious?
It's usually more fleshy. It grows faster. It can be a tender, ulcerated nodule with a hard, indurated, or firm base. It often has a lot of keratin, so it has a crusty, scaly top.
And it has precursors, right? It doesn't just appear.
Often, yes. Actinic keratosis. These are those rough, sandpaper-like spots you feel on the scalps of bald men. They are pre-cancer. If left alone, a small percentage will turn into an SCC.
There's a specific type of SCC that is a favorite for surgical exams. The Marjolain's ulcer.
Ah, yes. This is a fascinating and tragic entity. A Marjolain's ulcer is an SCC that grows inside a chronic wound or an old burn scar.
So a patient who was burned 30 years ago suddenly gets an ulcer in that scar.
Exactly. The metaphor is that the tissue is it's exhausted. After decades of constant turnover and inflammation trying to heal that scar, the DNA repair mechanisms just give up. The cells mutate, and these cancers are often very aggressive.
So the lesson is, any change in an old scar needs a biopsy.
Always, without question.
One last SCC variant, the keratoacanthoma, the volcano.
This thing is dramatic.
Right.
A patient comes in and says, "Doctor, this lump appeared 3 weeks ago and it's huge. And it looks just like a volcano with a central plug of keratin, which is the lava."
And it grows that fast.
It's explosively fast. Paradoxically, it can sometimes heal itself and just disappear. But because it looks exactly like an aggressive SCC under the microscope, we don't wait. We cut it out.
Better safe than sorry. Okay. We have arrived at the final boss, part 6, the black spot, malignant melanoma.
This is the one. This is what keeps dermatologists awake at night. It is responsible for the vast majority of skin cancer deaths.
We know sun is the cause, But is it the same kind of accumulated sun as the others?
No, that's a great point. BCC and SCC are often related to cumulative exposure, the farmer who's out every day for 40 years. Melanoma is often related to flash fry exposure.
Flash fry.
The office worker who is pale all year, then flies to Spain for a week and gets absolutely roasted. Blistering sunburns, especially in childhood, are the biggest risk factor.
Let's talk about the types. The book lists 4 main ones.
First, superficial spreading melanoma, SSM. This is the most common, about 70% of cases. The good news here is that it has a long horizontal growth phase. It spreads sideways across the skin before it dives deep.
That gives you a window of time to catch it.
It does. Second one, nodular melanoma. This is the killer. It has practically no horizontal phase. It just starts diving deep immediately. It presents as a blue-black lump, often bleeding. It's terrifyingly fast.
Okay.
Third, lentigo maligna. This is the slow burn on the faces of the elderly. It looks like a large, irregular brown stain that just grows over years.
And the fourth. This is the one people miss, isn't it?
Acrolentiginous melanoma. This appears on the palms, soles of the feet, or under the nails.
And this is particularly significant for patients with darker skin.
Hugely significant. While Caucasians tend to get melanoma on their backs or legs, in African, Asian, and Hispanic populations, acromelanoma is the most common subtype. This is what Bob Marley died from. A lesion under his toenail that was ignored until it was far too late.
And speaking of nails, there is a sign called Hutchinson's sign.
Crucial. Absolutely crucial. If you have a dark line on your nail, it could just be a bruise. But if the pigment spills out onto the nail fold, the cuticle skin around the nail, that is Hutchinson's sign. And that is almost certainly melanoma.
Okay, we've diagnosed it. Now, for what might be the single most important concept in this entire chapter, prognosis.
It all comes down to one number. Breslow thickness.
What is it?
It is the depth of the tumor in millimeters. The pathologist takes the slide and measures from the granular layer of the epidermis right down to the deepest melanoma cell they can find.
And why does depth matter more than, say, width?
Because the blood vessels and the lymphatics are deep in the dermis. The deeper the tumor dives, the more likely it is to hit a vessel and spread to the brain or lungs. A huge, wide melanoma that is very thin has a better prognosis than a tiny, narrow one that's deep.
And this Breslow number dictates the surgery.
It dictates the margin, how much of a safety buffer we have to cut around it. Baily and Love gives us the rules of thumb. If it's in situ, so it hasn't dived at all, you take a 5 millimeter margin. If it's thin, so less than 1 millimeter Breslow depth, you take a 1 centimeter margin. If it's getting thick, over 2 millimeters, you need a 2 centimeter margin.
And 1 centimeter versus 2 centimeters might not sound like much, but on a person's face, that's a huge difference.
It's the difference between closing it with a simple stitch and needing a complex skin graft.
What about the lymph nodes? How do we know if it has already jumped ship?
We use a sentinel node biopsy. We inject a radioactive tracer and a blue dye into the scar from the first biopsy. Then we watch where it flows. The very first lymph node that turns blue or becomes radioactive is the sentinel. We take that one node out and check it.
And if the sentinel node is clear?
Then the rest of the chain is likely clear. You're safe. If the sentinel has cancer in it, you know the disease is at least stage 3.
And if it's spread everywhere? 10 years ago, that was a death sentence.
It was grim. Very grim. But now we have BRAF inhibitors.
How do they work?
About 50% of melanomas have a specific mutation in a gene called BRAF. It's like a light switch that's stuck in the on position, telling the cell to divide constantly. Drugs like dabrafenib block that switch. They turn it off.
And the effect?
Can melt away tumors in weeks. It's not always a permanent cure, but it has completely revolutionized survival in metastatic disease.
Science is amazing.
It truly is.
We have covered a massive amount of ground today. I mean, from the Velcro of the dermoepidermal junction to the woodiness of neck fasc and the rules of Breslow thickness.
It's a marathon of a chapter.
Let's do a final ward round recap. I'm going to throw some clinical cues at you. You give me the diagnosis or the key concept.
Okay, I'm ready.
Pain out of proportion to clinical signs plus crepitus.
Necrotizing fasciitis, immediate surgery, no quatin.
A pearly rolled edge on the side of the nose.
Basal cell carcinoma.
Honey-colored crusts on a child's chin.
Impetigo.
An ulcer that's growing in an old burn scar.
Marjolin's ulcer, which is a squamous cell carcinoma.
Pigment spreading from a nail onto the nail fold.
Hutchinson's sign. Acromelanoma.
You passed, doctor.
What a relief.
Listener, thank you for scrubbing in with us. This was heavy, I know, but knowing this stuff saves lives.
And please, I cannot stress this enough. Go look at the pictures. Open Baily and Love, chapter 45. Dermatology is a visual sport. You need to train your eye to see the difference between a pearly BCC and a crusty SCC. You cannot do that with audio alone.
Use this as your primer, but always verify with the text.
Before we go, I just want to leave you with one final thought. We often treat the skin as just the wrapping paper. We obsess over the heart and the brain. But as we saw with Gardner syndrome or those choke vessels keeping a flap alive, the skin is an integral part of the whole machine. It is often the dashboard warning light for the engine inside. So when you look at a patient's skin, don't just look at it, look through it.
Powerful advice. The skin tells the story. Thanks for listening to The Deep Dive. We'll see you on the next Word Round.
Goodbye.